It is my pleasure to call upon Dr. Sanjay Chaudhary. He has been doing Phakic IOLs from a long time now, extensive experience with Phakic IOLs, and he will be talking on how to do the perfect IOL, Phakic IOL procedure.
Thank you, Dr. Shri. So, thank you, Dr. Kundlu, for giving me this opportunity. And when you said perfecting a Phakic IOL in 2023, I was wondering what exactly are we talking about in 2023? What is the latest? What are we thinking? So, I realized that even in 2023, people are still they're adapting to phakic IOLs is coming up, but not the way we thought it is coming up. There still are fears in the mind of a common ophthalmologist about phakic IOLs and its complications. So maybe it's time we should alleviate those fears. So over 15 years, some of us here have implanted several thousand phakic IOLs on the dice even. We have used all types of phakic IOLs, be it the Star, the Care, the Biotech, the Medinium. We have faced all types of complications in this period. And we have put our minds on how to prevent these complications. And we have been successful to some extent. How? The two main fears still lurking in the mind of most of the ophthalmologists who want to transition to this technology is the fear of glaucoma and the fear of cataract. Let me see if I can help you out a little bit on these two counts. First, the fear of glaucoma. If ICL is inserted under visco, and which is the most common way of inserting a phakic IOL, there is a disadvantage, and the disadvantage is that visco, which is trapped between the haptics and the sulcus at the periphery, cannot be removed fully. Residual visco can clog the trabecular meshwork and cause a post-op rise in IOP. And this is fairly common. I'll show you the video and show you the reason why this is fairly common. Now, in this case, I had thoroughly removed the visco for a minute, but when I took my irrigation aspiration out, the IOP came down and the vitreous started moving in under the ICL from the periphery to the center, and through the central hole, it kept coming out and out and out and out and out. See, despite the 1 minute of irrigation aspiration, there is still visco there, which was trapped in the haptics. And I do a little irrigation again to take out this visco, and the moment I come out again, the pressure comes down and then more visco starts coming out. So you can imagine how much of visco is still getting retained even after a thorough visco removal of 1 minute. So, Dr. Shri Ganesh was the pioneer who talked about putting ICLs under Helon GV. And it is doing very well. Even I did that. I was very happy with the technique. Advantage, ease of insertion, chamber very well maintained, and the whole thing comes out in one bolus because Helon GV has molecular chains. So there is no blocking of the trabecular meshwork and no early rise of IOP. It was a fantastic technique, but in one case I encountered a problem. And I probably attributed it to this. Maybe Dr. Shri Ganesh may be able to correct me. I felt that there was a rise in IOP and probably there was some kind of a break in the molecular chain trapped between the haptics and the sulcus. So it is not necessary that the whole thing has to come out in a bolus. Something could break in the molecular chain and still get trapped. And those residual pieces may dislodge, come towards the trabecular meshwork and block the trabecular meshwork. And these pieces dissolve very slowly. So the IOP rise may be prolonged. I may be wrong in my assumption, but I assumed that was probably the reason. So I thought, why not do away with all the viscoelastics? And I went on to a technique called hydroinsertion. Hydroinsertion has its advantages because you are not using any viscoelastic. The viscoelastic is only in the injector, which is minuscule, and it is just floating around that minuscule threads, so it gets sucked out very easily with minimum irrigation aspiration. And early rise of IOP is virtually non-existent. In my last 3,000 cases over 4 years, I have not faced even one case of rise of IOP. So that is a very strong testimonial that says that the hydroinsertion works very well in this situation. No irrigation under the ICL has to be done, because we know and it is documented that if you go under the ICL to irrigate, there's a risk of cataract, which is not here. Surgery time is reduced to just 5 minutes. Whole surgery is done with just 30 ml of fluid. So minimum irrigation, your corneas are crystal clear the first post-op day. So it is a win-win situation doing insertion under hydro. So here is my present day hydro insertion technique. And just see the ease with which the whole process is done. ICL injected, IOP is just 40 here. Irrigation aspiration for just 5 to 10 seconds. All the viscose strands are over. Tuck in, bring the ICL into the right axis and tuck. It looks very simple. The whole procedure done in just 5 minutes. 30 ml of fluid. No visco, no early rise of IOP. I am kind of sold to this kind of a procedure, and that is why I talk about it. But then the problem with people is that early users, beginners may face a problem. The second fear is the fear of cataract, the bigger fear. Can I help you reduce your fears on this count? So if ICL is inserted under visco, the disadvantage is that it needs a lot of irrigation to get that visco out from under the ICL. Excessive irrigation or irrigation under the ICL can cause a cataract. So here's the case. First post-op day, there was this kind of a haze and this kind of a presentation on slit lamp. And initially, when you were talking about this some 10 years back, we said this is visco on the crystalline lens. It looked typically like a visco on a crystalline lens. However, these dissolved over time. So we looked up the literature when we had a couple of cases like this, and the literature said that there could be anterior subcapsular vacuolar changes of the crystalline lens, and the conclusion was that it is because of direct irrigation in that space between the ICL and the crystalline lens, and these are transient, and there is a spontaneous reversal. We were happy. There was spontaneous reversal. We were encouraged. However, we had another different scenario. A diffuse anterior subcapsular cataract, and we
Sanjay,
waited.
we have one more speaker, so.
Okay. Yeah. So this we expect would dissolve, but it didn't. It kind of collected towards the center, and it developed into a frank cataract, and it had to be removed as a cataract. So the inference was, do not irrigate between the ICL and the crystalline lens. And it is not just the anterior vacuolar changes, but cataract can also happen. So the last advice is a small video clip that what I advise to the beginners, that instead of doing under hydro only, you do it under visco, place the ICL under visco on the iris, then remove the visco when the ICL is over the iris, because now there is a huge gap between the ICL and the crystalline lens, and there is no visco getting trapped in the haptics of the ICL, and then you tuck it in. Thank you so much.
Thank you.